Introduction. ARC has received numerous inquiries from PSOs and providers alike on how a provider should set up a patient safety evaluation system, or PSES, when working with a PSO. The concept of a PSES is extremely flexible and not directive. For example, a PSES for a solo practitioner is likely to be less complex than one set up for a large academic medical center. A PSO's PSES will likely become more complex as the PSO works with more providers and as the volume of information the PSO evaluates increases. As a result, there is no single approach that must be followed. That's why the model that we will review is called Working with a PSO One Approach. It is intended to raise many, but certainly not all, of the issues that a provider should consider when setting up its PSES. Key documents. First, throughout the presentation, we will refer to three key documents: the Patient Safety Act, formerly known as the Patient Safety and Quality Improvement Act of 2005, the proposed implementing regulation known as the Notice of Proposed Rulemaking, or NPRM, the final implementing regulation known as the Patient Safety Rule, the final rule, or just the rule. The Patient Safety Act is the statute enacted by Congress in 2005, which confers confidentiality and privilege protections on information in certain situations when providers work with federally listed PSOs to promote shared learning to enhance quality and safety. The NPRM was issued in early 2008. While it does not have the force of law like the Patient Safety Act and final rule do, it is important because it provides a more extensive discussion of the Department of Health and Human Services interpretation of the Patient Safety Act. This is especially true of the two major concepts we will discuss today: the pathways for information becoming Patient Safety Work Product, or PSWP, and the role of a provider's PSES. The NPRM also outlines the overall framework and intent of the final rule. Finally, the department used the NPRM and the public comments received on it to form the basis of the final rule. The final rule became effective in early 2009 and established regulations to implement the Patient Safety Act that PSOs must follow. The final rule provides more detail on how the department implements the broad requirements of the Patient Safety Act. Caveats. This presentation is a high-level introduction to these topics. As a result, it should not be regarded as a complete or comprehensive resource and does not constitute legal advice. For technical assistance, you can submit questions to ARC by sending an email to pso@ahrq.hhs.gov. Background. This diagram of a provider and PSO PSES includes references to a number of different provisions and requirements of the rule. We will first provide a brief overview of two key concepts: protection of PSWP and the role of a PSES. PSWP, what is it? Patient Safety Work Product, PSWP, is the term for information that is subject to the confidentiality and privilege protections of the Patient Safety Act and Rule. Privilege protections. Privilege protections limit the use of PSWP in judicial and administrative proceedings in U.S. jurisdictions. These protections mean that PSWP is not subject to subpoena or order, discovery, or disclosure pursuant to the Freedom of Information Act. PSWP cannot be admitted as evidence in any civil, criminal, or administrative rulemaking or adjudicatory proceeding. PSWP also cannot be admitted in a professional disciplinary proceeding of a professional disciplinary body established or specifically authorized under state law. The decision maker in a proceeding where PSWP is sought shall determine whether the PSWP is privileged or not. HHS will not make this determination. Confidentiality protections. HHS Office for Civil Rights interprets and enforces the confidentiality protections that apply to PSWP. The rule does not limit the internal use of PSWP within a PSO, a provider, or another holder of PSWP, but the rule limits the ability to disclose PSWP and specifies the only reasons that PSWP can be permissibly disclosed. To understand the significance of these limitations, review the definition of disclosure at the beginning of the rule, as well as the specific reasons for which PSWP can be permissibly disclosed in Section 3.206B of Title 42 of the Code of Federal Regulations. PSES, what is it? To fully appreciate the concept of a PSES, the definitions of PSES and PSWP must be read together. The PSES is defined as the collection, management, or analysis of information for reporting to or by a PSO. The reference to reporting to or by a PSO means that a provider and a PSO will each have a PSES that is separate and distinct. PSWP is likewise broadly defined. The introductory language of the PSWP definition outlines broad categories of information that can become PSWP. These include any data, reports, records, memoranda, analyses such as root cause analyses or written or oral statements. As we shall discuss shortly, the definition also describes information that is not PSWP. So it is very important that you closely read the type of information that is excluded from becoming PSWP. Reading the PSWP definition and its exclusions in the rule will broaden your understanding of the role a PSES can play in separating what is PSWP from what is not PSWP. The definition states, for example, that PSWP does not include information that is collected, maintained, or developed separately or exists separately from a patient safety evaluation system. The PSWP definition also helps you more fully understand a PSES. It clarifies to ensure that information reported by a provider to its PSES is appropriate for reporting to a PSO. Some hospitals review information before and after it enters the provider's PSES. The review will determine whether the information is ineligible to become PSWP and/or was collected or developed for purposes other than reporting to a PSO. Information that meets either of the above criteria cannot become PSWP. It matters whether deliberations or analyses are performed within or outside a PSES. While there is no requirement that a provider document its PSES, documentation is a best practice. If another party seeks access to information a provider believes is PSWP, a provider may need to demonstrate that it complied with rule requirements regarding a PSES and how it distinguishes the PSES from its other activities in order for the information to stay protected. If information could improve patient safety, healthcare quality, or healthcare outcomes, it can always become Patient Safety Work Product, or PSWP, through reporting to the PSO. Choose one. True, false. False. The fact that information could improve patient safety, healthcare quality, or healthcare outcomes meets only one of the two criteria for information to become PSWP through reporting. Unless the information was also assembled or developed by the provider for reporting to a PSO and is reported to a PSO, the information does not meet both requirements of the PSWP definition. See the discussion of what is excluded from becoming PSWP in the preamble to the final rule, and for further background, the NPRM. PSWP, 2 pathways for providers to develop PSWP. Now we will turn to the 2 pathways a provider can use to develop PSWP and the role of a provider's PSES in each. Pathway 1, Reporting Pathway, getting information to a PSO. The first pathway is used when a provider assembles or develops information that is eligible to become PSWP for reporting to a PSO enters the information into its PSES, and then reports the information to a PSO. There are a number of requirements and exclusions related to information that can become PSWP in this way, and we'll return to them shortly. Pathway 2. Conducting specified activities in a PSES. The second pathway enables a provider's deliberations or analysis to become PSWP, but only when they are conducted in its PSES. Information that identifies the fact of reporting to a PSES can also become PSWP through this second pathway. Pathway number 1. Reporting pathway. Additional information. As we just mentioned, not all types of information can become PSWP through the reporting pathway. Now let's discuss information that is excluded from becoming PSWP based on the definition of PSWP. This will help explain how information is categorized in the PSES diagram. We are going to focus on how information becomes PSWP through reporting to the PSO. We will call this the reporting pathway. Information reported this way will be protected if it meets 2 criteria. The information could improve patient safety, healthcare quality, or healthcare outcomes, and the information was assembled or developed for the purpose of reporting to a PSO, not for other purposes. Unless both criteria are met, the information itself cannot become PSWP. Meeting the first criterion is relatively easy. Healthcare providers develop a great deal of information that could be used to improve quality, safety, or healthcare outcomes. However, further explanation of the second criterion may be helpful. A provider cannot designate its existing information as PSWP if that information was prepared for another purpose. Only information that was originally assembled or developed for reporting to a PSO meets this criterion. Reporting pathway. Information that cannot become PSWP. Now let's focus on information that cannot become PSWP because it was developed for other purposes. Some common examples of information prepared for purposes other than reporting to a PSO are the patient's medical record, billing information, and discharge information. The NPRM and the preamble to the final rule provide other examples of information assembled or developed for other purposes, including information developed for traditional risk management activities, information needed to fulfill external reporting or record-keeping obligations, information needed to meet Medicare conditions of participation, and a number of other excluded purposes. In part because data collection can be costly and labor-intensive, the purpose for which information is assembled or developed is generally established before data collection begins. For example, if information was developed for claims management purposes, it was not assembled or developed for the purpose of reporting to a PSO and cannot become PSWP. Similarly, information developed for operational purposes, such as security videotapes, was not assembled or developed for reporting to a PSO, so it could not become PSWP. These types of information can still be shared with a PSO, but original records at the provider's facility cannot be considered PSWP. Reporting pathway. The concept of a copy. Consider for a moment a report of an adverse event in an operating room. The report is likely to include information from the patient's medical record, specific details of what occurred in relation to the patient's surgery, and a description of the potential causes of the event. Making all of this information available in the report to the PSO will contribute to the PSO's ability to conduct meaningful analysis and provide valuable feedback to its providers. Under the rule, the information prepared for and reported to the PSO is PSWP. However, the original records created for another purpose, such as medical records, cannot become PSWP and are not eligible for PSWP protection. In these situations, PSWP protections apply only to the copy of the information assembled for reporting to the PSO. Therefore, a provider could have multiple versions of the same information where one version of the information is confidential and privileged PSWP, but other versions held outside the PSES are not. This concept is not limited to factual information regarding an event. The same principle applies to a report prepared for other purposes. For example, if a provider prepares a report for its liability insurer, the provider can report a copy of its analysis to the PSO. The copy would be PSWP, but the original report maintained outside the provider's PSES would not be PSWP. The concept of a copy is reflected in the diagram we will review shortly. Before we do, there are two other concepts related to the reporting pathway for us to review. Reporting pathway. Information can become PSWP when entered into a provider's PSES. The rule enables a provider to make information PSWP the moment a provider enters the information into its PSES. By dating and documenting the information upon entry, the information becomes PSWP. Specifically, this means document the date as the information enters the provider's PSES, document that the information is within the provider's PSES for reporting to a PSO, ultimately report the information to a PSO. Such information must also meet the general requirements of the reporting pathway. The information could improve patient safety, healthcare quality, or healthcare outcomes, and the information was assembled or developed for reporting to a PSO. Information collected in a provider's Patient Safety Evaluation System, or PSES, is always considered PSWP even if a provider has not documented or dated it. Choose one. True, false. False. The definition of PSWP requires that in addition to being documented and dated, information must be assembled by a provider for reporting to a PSO and could improve patient safety, healthcare quality, or healthcare outcomes. Reporting pathway. Information can be removed from a provider's PSES. Dropout. The preamble to the final rule cautions providers to only enter information into its PSES that it intends to report to a PSO. Thus, if the information is needed for other purposes, it is recommended that a provider not place such information in its PSES. However, sometimes a provider cannot determine whether reported or incoming information is needed for another purpose until the information has been analyzed in the provider's PSES. When that happens, a provider can remove or drop out the reported information from its PSES. In other words, removing information that the provider entered into its PSES, as long as the information has not yet been made accessible to a PSO. What cannot be dropped out are the deliberations or analyses that were conducted in the PSES. The process that the provider must follow to drop out information that has been reported to its PSES is the mirror image of the dating and documenting process the provider followed when it entered information into its PSES. Only information that has not been reported or made accessible to a PSO is eligible for dropout. Must document the act of removal and the date it removes the information from its PSES. This only applies to the reporting pathway. Upon removal from the PSES, the information is no longer PSWP. It is important to note that information that has been dropped out of the provider's PSES and used for another purpose cannot be re-entered into the PSES at a later date except as a copy. The original information itself remains outside of the PSES and is unprotected. It is also important to note that any analysis or deliberation that takes place in the provider PSES cannot be dropped out. Pathway number 2. Conducting specified activities in a PSES. The second pathway for providers to create PSWP occurs when a provider conducts deliberations or analysis in its PSES. It is important to recognize that this pathway is separate and distinct from the reporting pathway. Let's discuss some important features of this pathway for creating PSWP. The deliberations and analyses are considered PSWP the moment they take place in the provider's PSES. Neither deliberations nor analyses can be dropped out of the provider's PSES. Deliberations or analyses that took place outside of a provider's PSES can never meet the requirements of the reporting pathway. Only a copy of such information created for reporting to the PSO can become PSWP, which means that the original analysis or deliberation held by the provider is not PSWP and not subject to the Patient Safety Act's protections. For example, reporting minutes of a meeting conducted outside the provider PSES does not make the original deliberations reflected in the minutes PSWP. A provider can protect information in its PSES that was assembled or developed for purposes other than reporting to a PSO by dating and documenting the information. Choose one. True, false. False. Information assembled or developed for other purposes does not meet one of the two requirements for information to become PSWP. Thus, only a copy of such information prepared for reporting to a PSO can be protected. The diagram. As you see here, the diagram begins with a focus on the broad category of patient safety and quality information collected and developed by the provider. Much of this information is collected or developed to meet licensure, regulatory, or other operational needs of the provider and would therefore not be eligible to become PSWP. To make that determination, this provider has established a triage process reflected in the box immediately below. The triage process. Note that this provider chose to conduct its triage outside its PSES. This provider understands that it should not report information into its PSES unless the provider intends to report the information to a PSO. So the provider has taken the cautious approach and conducts its triage process outside of its PSES. This approach helps decrease the possibility that information will routinely be replaced in its PSES that is not eligible to become PSWP. The results of the provider's triage process are reflected in the next row of boxes. The box on the left is for information that is eligible to become PSWP, and the box on the right is for information that itself cannot become PSWP. These two boxes are intended to describe the sorting that takes place during the triage process. In practice, information that is determined eligible to become PSWP could then directly enter the provider's PSES. Let's consider what questions a provider might ask during the triage process. First, could this information be used to improve patient safety, healthcare quality, or healthcare outcomes? If it cannot, the information cannot become PSWP, nor can a copy of the information become PSWP. Second, if the answer to the first question is yes, the next question is, why was the information originally collected or developed? If it was collected or developed for a purpose other than reporting to a PSO, the information cannot become PSWP. The most obvious examples of information collected or developed for another purpose are those stated as exclusions in the definition of PSWP: the patient's medical record, billing data, and discharge information. The exclusions are represented in the first line of the box to the right. But there are many other examples of information developed for other purposes. The three listed sub-bullets provide examples of information collected or developed for other purposes. An example of information developed for corporate requirements is information that a provider needs to collect or develop for risk or claims management purposes, whether the provider is working with a PSO or not. Licensure, regulatory, or other professional bodies may require providers to collect and/or maintain certain types of information for an on-site inspection or survey. Because there are limitations on disclosure of PSWP, A provider needs to determine what information it will maintain as non-PSWP in order to satisfy the requirements of external authorities. The final bullet refers to information collected or developed for other business purposes, such as healthcare reimbursement or malpractice claims management, which cannot become PSWP. The dotted arrow from this box of ineligible information indicates that a copy, but never the original of such ineligible information, can become PSWP. This enables a provider and, in turn, a PSO to take into account a much broader array of information. In order to determine whether a copy of ineligible information can become PSWP, the same two questions are asked as during the triage process. This copy protection is available when the copy meets the same two requirements for reporting. One, it could be used to improve patient safety, healthcare quality, or health outcomes. And two, the act of making a physical or electronic copy of the information is solely for reporting to a PSO. Operating in a provider's PSES. In the box titled Provider PSES, the first line refers to an option that the reporting pathway makes available to a provider before eligible information has been reported to a PSO. That is, if a provider documents that the information is within the PSES for reporting to a PSO and records the date that the information is entered into its PSES, the information has now become PSWP. However, the provider must still report the PSWP to its PSO. If a provider chooses not to date and document the information under the reporting pathway, it does not become PSWP until the information is reported to a PSO. The second line references analyses or deliberations conducted in the PSES, which become PSWP at the moment they take place, as we have discussed, which occurs separately from the reporting pathway, while dropout can occur for information entered into the PSES via the reporting pathway. Analysis or deliberations conducted in the provider's PSES cannot be dropped out. The third line refers to the dropout provision. Despite a provider's best efforts during triage, a provider may discover during analysis of information brought into its PSES that it wants to remove specific information from the PSES. For example, the information may now be wanted for other purposes. As long as this incoming information has not yet been reported to a PSO, the provider can drop out the information from its PSES. The information would no longer be PSWP and thus not subject to the Patient Safety Act protections. The documentation and dating requirements that we have discussed must occur when information is dropped out of the PSES. If information is dropped out of the provider PSES and then used for other purposes, only a copy of the information is eligible to become PSWP through the reporting pathway thereafter. The fourth activity listed in the provider PSES box involves preparing the information for reporting to a PSO. One final thought. The rule permits a provider to use PSWP within the entity. However, it is useful to remember that information maintained outside a PSES is not PSWP. Complying with the requirement to maintain PSWP in its PSES may also assist a provider in minimizing unintended impermissible disclosures of PSWP. The PSO's PSES. PSOs are expected to establish secure transmission between the provider's PSES and the PSO. The provider's PSES is separate and distinct from the PSO's PSES. This link will enable providers to report PSWP to the PSO and, in turn, receive feedback from the PSO in a secure manner. The arrow on the left from the provider PSES to the PSO PSES reflects the process of reporting to a PSO. There are two ways that providers can report information to its PSO. The first is physical or electronic transmission at the provider's discretion. The second way that a provider can report information to its PSO is known as functional reporting. Under this approach, information is reported to the PSO at the moment that the information in the provider PSES is accessible to its PSO. For example, a provider could give a PSO access at all times to data on a specific server in its PSES. Or a paper-based provider might simply designate a room in the provider's facility to which the PSO has 24-hour access. A contract between the provider and its PSO could describe how functional reporting would occur. That is, the provider and its PSO should agree in writing precisely when the PSO has authority to access the information. It is important that this be clear between the parties because information is considered reported to the PSO at the moment the PSO has access. The point at which the PSO has access should be specified in writing. Once the PSO has access to the information, the provider can no longer use the dropout provision because reporting has taken place. We'll now turn to the box titled PSO PSES. The PSO must perform the 8 patient safety activities defined in the Patient Safety Act and Rule to remain listed. Among these activities, a PSO must collect and analyze PSWP and provide feedback to providers in the provider's PSES. The upward arrow from the right side of the PSO PSES to the provider PSES represents the pathway for providing such feedback. PSO Privacy Protection Center and the NPSD. A PSO can also voluntarily choose to contribute data to the Network of Patient Safety Databases, or NPSD, authorized by the Patient Safety Act. The goal of the NPSD is to further additional insights into the causes of and strategies for preventing adverse patient events, as well as to improve quality. The Patient Safety Act requires that the NPSD only accept non-identifiable data. This was intended to ensure that data reported to the NPSD could not be used against providers. AHRQ has established the PSO Privacy Protection Center, or PPC, to assist PSOs in rendering data non-identifiable according to the standard in the rule. Thus, the diagram shows data first going from the PSO PSES to the PSO PPC, and once the information is confirmed to be non-identifiable to the NPSD. Conclusion. As this diagram makes clear, a provider's PSES is central to the creation of PSWP through both the reporting pathway and for the specified activities in a PSES pathway. While there is no requirement to document a PSES, it would be a best practice as it would bolster providers' efforts to assert that information within its PSWP and therefore is privileged and confidential. In closing, please keep in mind these key points. There are 2 distinct pathways for a provider to create PSWP. The provider's PSES and the PSO's PSES must be separate and distinct from each other. For information to be protected through the reporting pathway, it must be able to improve patient safety, healthcare quality, and be assembled or developed for reporting to a PSO. Deliberations or analyses can be protected only if conducted in the provider's PSES. We encourage you to go back and review this video again in sections if you have only limited time in order to embed these concepts in your mind. Once you incorporate processes and procedures into your workflow along the lines we've discussed, it is our hope that providers will feel encouraged to participate more fully in reporting and analysis while working with a PSO. This will ultimately result in better and safer patient care. If you have further questions, do not hesitate to contact the AHRQ PSO program via email at pso@ahrq.hhs.gov.